we're going to do now is move on to the second section. So we're going to talk about shared decision making. And I do have some questions on that as well. So given the time, we have to think about how we answer them. So make sure you give your point and say your point. I don't want you to miss out on saying that. So do feel like we come back. Maybe if we take 5 of you answer the first question, 5 of you answer the second question or something, just to try and hurry us along. But I don't want you to miss out on having your say. So let me quickly share my, in fact, what I'll do is I'll put the questions in the chat. And the first one is, do you feel that your healthcare professionals introduce choice into discussions with you about how to manage your health concern or condition? I'm going to put the questions in the chat. Who would like to go first? And like I said earlier, I know this might be a bit more personal. So if you don't feel comfortable to share or talk more generally, that's absolutely fine. But you put your hands up. So brilliant. Meg.
Yeah, so I think things are changing, and some healthcare practitioners are definitely better than others. Some are very good at having the conversation and include you very much as an equal partner in that conversation. Some you get the impression that they are aware that they're supposed to be having those conversations, but don't really know how to do it. It's quite often in those cases framed, or in my experience, framed as a blunt, what do you want me to do about this? Which is kind of getting at it, but it's lacking the nuanced conversation that is probably necessary. And then I think that some are just blithely unaware of the concept, although I do think that that number is decreasing as perhaps it's getting more and more encouraged within their own workforces.
I love that point about how some people are aware that they need to do it, but they don't know how to. And that's probably a lot of people's experience. Okay, Carol.
Yeah, it's interesting, that one, because I was an honorary lecturer at Manchester Medical School, and I gave a lecture to the students, and they asked me how to, because one of the things I said was about talking to patients, and they put their hand up and said, well, how do you talk to patients? So I think that's something that, you know, a lot of clinical people, a lot of medical professionals have lost the ability to just chat. They've lost the ability to communicate. When, you know, when you have a consultation, you should have a communication, and they kind of have forgotten that bit. So I think the answer to the question is, have I experienced it? Yes, some doctors, with some medical professionals, yes, and with others, no. And have I been supported in decision making? No, you know, with decision making, the answer is no. And did I know about decision making tools? And the answer to that is no. And if I don't know about it, I mean, I tend to know, you know, make a point of finding out about things. So, you know, not much hope for sort of Joe Public, is there, really?
Thank you. Good point. Okay, number 3, Naomi, you next.
Not when I was a child. When I was in inpatient services when I was a child, I didn't feel that I had any control over any of my care. I don't feel like I was informed. I don't feel like I was given any choice over anything. I think as an adult slightly more, but I still feel that there are some professionals that just always feel that they know better. And even if you kind of feel differently, they'll kind of try and persuade you to think their way. They don't kind of I have felt quite pushed into their decisions as if they're the right ones, and they'll just try and convince you that they're the right ones, even if you know that it doesn't kind of feel right for you, and it can feel quite intimidating. So I personally don't feel like I have been that listened to regarding my care, no.
Shame. Aurora, thank you for that, Naomi. Aurora.
So I think I am with others. We have a similar, obviously, experiences. It's just sometimes some clinicians presented some option clearly and involved in decision making, but others tended to recommend a set of paths without fully exploring alternative or asking what mattered to me the most. So on occasion it's quite frustrating to be passive recipient of service.
And what I'm hearing as well from all of you, you know, you're saying that you're not feeling listened to. I think you said it like that, Naomi. So you're not, and that's the bit, isn't it? So even if it ends up that you follow their path and their decision, at least feeling like they've heard what you've said. Sarah. Can you come off mute? There you are.
Yes. I found that very often the clinicians can be selectively communicative, especially if you put forth, especially in trying to negotiate shared decision making, and you put forth a good argument, and it doesn't align with their point of view. They can't argue against your argument, and so they suddenly decide to tell you that, oh, we've covered this before. They haven't. So it's not just a question of whether or not they're good at communicating. Very often it's a question of whether or not they want to communicate, are willing to actually engage in informed conversation with you. And I think this degree of paternalism varies across different types of medical profession, and is aligned often with the degree of power that professionals have. But again, within that, there's always individual variation.
Yeah, okay, thank you. Meg, you've still got your hand up. Did you want to make another point? No, okay. Rich.
Yes, two things which have already been mentioned. The first is from communication. At some the start of this kind of year, I started experiencing bleeding from my nose, which hadn't ever happened previously. And I was asked what might be causing it, and I said I'm really stressed. And he then said to me, what is causing your stress? And then started poking and prodding with my nose and didn't give me time to answer. And so I felt he wasn't even listening. And so yeah, communication is important, but it's about two things. It's not just talking, it's listening and it's being heard. And if you're not heard, you will not have any choice. The second example I've got, I was in the mental health work stream and a manager was trying to get a letter signed off. And I said, I've got some problems with this letter. There's important things missing. And all I got in return was a load of flannel, which meant I knew straight away this manager was patronising me, and I would have let it go, except another manager spoke up and said, well, actually I agree with you, Richard, things are missing. You're not talking about anxiety, you're not talking about depression. So that was an important point because it was about a referral letter to other health and professionals, and I hadn't been heard. I had been patronised. It was all about power, and so the only way things improved was there was another manager into the room who was able to speak up for me.
Okay, so it was actually having someone there on your behalf to have your back, if you like, that spoke up for you. Thanks for sharing that, Rich. I'm just going to mute you because it's very loud where you are there. Thank you. Rob.
Yeah, I mean, I can provide some great examples of decision making in a life-threatening situation where communication was first rate. That was when I was diagnosed with 2 types of cancer, and I wouldn't be here without the NHS and some of the great works and good communication coming from primarily my GP through to an acute cancer care setting. So yeah, everybody's got a different story to tell, but when it works well. I was involved
in terms of the decision making and your own decision making. Okay.
Yeah. In terms of decision making, it was made quite clear. You've got option A, option B,
right.
And then they talked through options A and option B, and they didn't rush me. It was responsive and effective care that was well led, quoting the CQC. I couldn't fault them.
Okay. So, thank you.
You can't dwell sometimes on the negative. We've got to also look at some of the positives, and that came down from clear communication from the primary care service. So, sometimes, a lot of the time, the NHS works well.
Yeah, I think that's what people are saying, that it's not that it doesn't work well. It's about being involved in your own care and sort of empowered, feeling heard in your appointments, isn't it? And I think that's slightly different. I think.
Yeah,
I think
absolutely.
there's. Oh, sorry.
No, go on, Amy.
I think there's also a difference between physical health and mental health, how they're treated as well. I think that can be a massive difference. I mean, obviously people aren't listened to in physical health as well, but I think sometimes in mental health that does happen even more so, because I think in physical health they can see the problem in front of them. With mental health, sometimes it can be hidden and they can't, and they're not always as willing to listen to you, because again, if it's mental health, they don't always think that you're able to make those decisions, so they make them for you. Patronised, yeah.
Just a quick interjection there. I agree. You know, I've had severe and enduring mental health problems for over 30 years, and I do draw those comparisons when I'm doing any teaching sessions. You're quite right on that.
You can see the you can see the difference.
You know, there's lessons to be learned, and if we start looking at people holistically, then I think we'd be a lot better off. So no, you are right with that.
Okay, thank you. Though, no, it's a good point, and it's worth saying there's positive experiences too. Amy.
Thank you. Yes, I think sort of connected with what Robert and Naomi were just saying. I think the more, I guess, if you're somebody that has a rather complex presentation, or if you have several things that might be going on, I think the more complicated you are, in some ways you're less likely to be heard. Because I think in a lot of instances you're kind of seen as a list of things. So people might see your records and they might see the various things that are supposedly wrong with you, and then they make their assumptions. And I think a lot of healthcare professionals do that, and they, once they've got something locked into their own brains about how they're perceiving you, then it actually doesn't really matter what you might say, because they've already made that decision. They're the professional, they know, they can see the list. This is how it works, this is what's going to happen, and then you're just kind of lost in that, and you're then fighting a losing battle. Obviously not in every instance, but I've certainly found with very senior medics who have got decades of experience, actually it can sort of work against them a bit, because then they're less open to maybe thinking outside the box, or just thinking actually that they might not know everything, just like, you know, we're all in that position. So I think sometimes having a bit of humility sort of can go a long way.
Nicely said. I think that feeds into what Meg's initial point, whereas there might be some of these older clinicians that really understand, say, decision making, but still don't know how to do it. I think that's kind of the point. Kirit.
I think for myself, it's about the relationship you have with that healthcare professional. If it's a long-standing relationship, then it's been positive. But also, the other thing I'd like to add is that, you know, I go there to my appointments informed. So if it's around diabetes, if it's around the latest drugs that are on the market, I go there and saying, right, I want to swap. And even though the conversation around cost, I say, I don't care about the cost. This is what's going to help me with my condition. And then we've got to negotiate. But I think if you go informed, then you have had a better outcome, I think.
That's a good point. Thank you, Kirit. Rob, did you want to say something else? No, it's just your hand still up. Okay, Rich?
It's also about the importance of information. When I first started using mental health services, I was offered a one-to-one service or group kind of therapy. I was offered CAT, CBT or CFT. I didn't know what any of those things were. However, I made a choice, and the first choice I made was wrong for me. And that was because the information I had wasn't sufficient.
Right. So that's the thing. I think that's feeding off each other's point there, Kirit, as well. You can go as informed as possible, and hopefully that helps with your care. But then you've only got the information that sometimes that they've given you.
And that's what I kind of put in the chat. Like I just put in the chat, like, if you don't know much about the options, then you can't really make an informed choice. They can give you a list of options, but if you don't know what any of those options are, then you can make a choice, but you can't make a correct choice, can you, for yourself? So
no, very good point. Okay, Hamid, last point before we move on.
Yes, please. What was the question? Because I had signal problems, keep dropping out. What was the last?
So it's about, do you feel that your healthcare professionals introduced choice into discussions with you about how to manage your health condition or concern?
I think they do their best. They do their best. When you talk, I'm a heart failure patient. I had open heart surgery. I've only had my recent appointment with a cardiologist, and he did his best trying to explain to me things. But sometimes the language can be quite technical, or it can be quite medical. Like 50.8 VLLVEE, and they say your heart is functioning at 50.0. I was like, I don't have a clue what this goes on. What does it mean? And stuff like that. And then they talked about all these different terms. So that can be quite. And I think if you're not confident, you usually want to just nod your head like you understand everything, and everything makes sense to you. But if you're confident, you might say, could you please explain that to me in a most simplest way? But time is always against you. So I had to come home and really Google things and YouTube things and try to make sense of what it meant, because I didn't have the confidence to say, can you explain that to me in a simplest fashion? So I want to end up on the fact that clinicians do try their best, but because they're so used to speaking that clinical language, they forget that you're not in that world. And for you, it's just French. You have no idea what they're talking about.
Do you think, what about letters, when we get the letters through the door? And sometimes I've noticed, even with my letters, they continue with that technical language. You've got to Google it to understand what they've said.
Yes.
Yeah.
And the worst thing is, this is going to make you all, it's interesting, is the medical secretary that writes the letters to you, when you ring her to say, I've just received this letter and her name's on there, there's more number on there. Could you please explain to me? And she's like, I have no idea. You need to speak to the consultant, psychologist, cardiologist, or the heart. And you're like, oh, but it says your name. She's like, I'm sorry, I still have no idea. So I think what they should do is really kind of put a contact details on the letter of the person who can explain, because it puts you in a very difficult position when they say to you, I have no idea.
Yeah.
And you think, well, you wrote the letter to me. I think.
Okay.
Thank you.
Sadia and Sarah, I can see your hands are up. I'm going to move on to the next question and come back to you, okay? Just with a quick hands up, who has ever known about decision-making tools, and were they made available to you? So hands up if you know of the decision-making tools. So 2 of you knew about them. They're not. So that means you weren't offered them because you didn't know. Okay, let's go to the next couple of questions. Did you feel that you were involved in reaching a joint decision with your healthcare professional? What could be shared with healthcare professionals to improve how we truly achieve shared decision making? Okay, so Sadia, let's go to you first.
I think for me, I felt like I wasn't listened to at all, that I had options I wanted to explore, but the doctor essentially was like, no. And I had several different options I wanted to explore, and essentially I was told, if you're not going to go on this medication, then I'm going to discharge you from our care. And I was like, well, I don't want to because it's making me sick. So for me, I feel like it wasn't a joint decision. It was, you either take this or I'm no longer helping you. And unfortunately, I couldn't take that medication because it was making me very ill. I have been in situations, for example, with my mental health care, where I felt like the decisions were very joint. My therapist was very clear with me what my options were, that we'd go with whatever I needed. And I remember one time it was a conversation that she started saying that I think what we're doing is working well. However, I think you might benefit from this other service, and sat down and explained it to me and said, what would you like to do? Would you continue with me? You've got another couple of sessions, or would you like to go to this one? And I happily went to the one because we actually had that time to talk over it, and for me to understand where she was coming from and how that fit in with my options.
Okay, thank you for sharing that experience. Before we go to the hands up, Sarah, I just wanted to come back to you because I know you had your hands up before. Sarah?
Yes, and just following on, I once had a bizarre experience, because it was when I was in hospital, detained under the Mental Health Act, but I became quite suddenly physically ill, and was diagnosed with an inguinal hernia, which is basically when part of your bowel, your intestines, has somehow managed to burrow through your muscular, abdominal wall, and is as a consequence of its escape attempt being strangulated by said muscular abdominal wall. And I remember a wonderful female surgical registrar telling me about all the possible choices and consequences, and then, but at the end, the pathway forward being left wholly to me. And for me to be in the context of being detained under the Mental Health Act, although at that point I was actually in a general hospital because I was in effect requiring emergency surgery, in which I had virtually no say over my care, but yet in the literally the life-threatening context of an inguinal hernia, because it was, the strangulation was such that in effect my gut was dying, I still had complete choice as to whether or not I could go ahead with the operation. And of course I did, because that was a sensible thing. But the contrast was bizarre. Over the little things in my life, I had no control. But in the physical because that was under the mental health services. But in the physical context, I had complete jurisdiction.
Yeah, a really interesting story, and I think further corroborates what I think we've all been saying a little bit about physical health versus mental health. So thank you for sharing that one. Okay, Meg.
So I take umbrage at the phrase shared decision making, to be honest, because it is a misnomer, because the only person making the decision should be the person whose body it is. And so I have railed against that term for quite a while. But I think there is a big lack of curiosity in some healthcare professionals, and I think this is some of what is feeding into the lack of these conversations not working quite so well. Sometimes when a policy says that it should be X pathway is recommended, and that might not be based on robust evidence or the newest evidence, and if they're lacking in that curiosity, then the conversation is fundamentally flawed. I think it is very much dependent on the person that's in front of you, and also how much time they have. And I think the more under-resourced they are, the less time they have to have those conversations, and that personal relationship-based care is really fundamental to having properly informed decision making and informed conversations to make that decision making happen. So yes, while I have had joint decision making with healthcare professionals at times, you can see that it is under pressure because of the lack of resourcing that they have and the lack of that training, for want of a better word, to have those conversations with people in the first place.
Thank you, really well said. I think builds on what Kirit had said earlier about that relationship. If you've got a relationship with that healthcare professional, that really helps your conversations. Aurora.
So joint decision making in my case happened sometimes, but when it worked well, it felt like a sort of partnership. The clinician also brought his expertise, but I brought to the table, number one, my value, and secondly, the context, because every journey is very, very personal. There were also times when decision felt rushed and also one-sided. And I'm thinking about the context of urgent care setting. I'm speaking only about physical health care. And sometimes is when the time is pressure from professional that this doesn't happen, I guess. I was in a space because of my work that was called Courageous Conversation, where healthcare professionals were sharing some very insightful comment. And they were very courageous to say this in this context, because they were saying sometimes we are very well aware of the overall impact on the health of a patient or a physical health condition, perhaps on his mental health, but we cannot ask him any question about mental health because we don't have time. And if you think sometimes, saying this out loud is you may have a sort of reaction from the person that is interacting with you. And then he was also saying that they are only seeing the specific scientific reason behind an issue, but they cannot go beyond that because of lack of time. So between the line I say, I'm sorry, but with the slot that I'm given, I cannot do more than that. And I do understand them after, seeing this comment from them. It made me, think a lot.
I think it's a really good point. I think in urgent care situations where you can't build those relationships, it's not an ongoing treatment setting where you're going every 6 months or whatever, then sometimes they have to make urgent, especially if you're not, what's the best, if you haven't got capacity to answer those questions, if you're unconscious or something. But I think that's a really good point as well that Meg made. It is our bodies. It's about our own bodies, and we should have complete right about what happens to it, shouldn't we? Really good points being made. Okay, Naomi.
I didn't feel that I was involved much in my care, as I said previously. So shared decision making wasn't really something that I experienced. Are we going over the end question now too?
Sure,
Or
go for it.
yeah, because I did write
Having
something
you
down for that
started
bit.
where it worked well, yes, go for it.
Yeah, because it's what could be shared with healthcare professionals to
Okay.
improve.
Go for it. Do that one.
Yeah. I think professionals need to understand the importance of person-centered care and that the patient is much more likely to engage with their treatment plan if they have been involved in creating it. I think they should engage more with those who have lived experience so that they can hear how beneficial shared decision-making is. Allowing the person to be involved in their care promotes their sense of self-respect and dignity and allows them to still have some autonomy over their life.
Really lovely. Really well said. Definitely send me those notes, please.
Okay.
Meg, you still got your hand up. Do you give it another point? No. Okay, so other people have an idea about what could be given to healthcare professionals. What kind of training? What do they need to understand to truly achieve shared decision making? I don't want to say it anymore now, Meg. I feel like it should be something else. Go on, over to you.
So this is where my background in maternity actually comes possibly very strongly helpful for non-maternity healthcare. I think that non-maternity staff could learn a lot from maternity, who work with out of guidance care an awful lot. And I think that they're, it's not all relative, but they're much better at supporting decisions that may not be recommended as per policy. But going off what the birthing person has decided is the best course of action based off the information from their own healthcare professional and possibly their own research as well. I feel that they are possibly one of the fields who are much better at this than some of the others within healthcare. Personalized conversations where they understand the individual in front of them. Like we said before, does that person just want to be told what to do, or do they want to be an active part of their care? Because that is something that varies as well, and that can only be taken when you actually have that relationship with somebody. You don't know who that person is in front of you, and if you're trying to speak to somebody who just wants to be told what to do, then trying to encourage them to make the decisions and think of all the different sources of information is just, it's going to be mind-blowing for them, and it's going to cause anxiety, whereas some people absolutely want to have all of that and be referred on to other sources of information as well. So I think it all comes down to time, curiosity, and removing the sometimes hierarchical, ego-driven nature of healthcare to allow those honest, nuanced relationships and conversations to develop.
Brilliant. Thank you, Meg. Really good points. Rob.
Well, I think it comes down to education again, doesn't it? I think it comes down to health professionals, whether it's doctors, nurses, anybody, as part of mandatory training, they have experience of listening to service users, carers, call us what you like. I think that's the important thing. It's up to, I think, the likes of the NMC, Social Work England and the CQC to make sure that as part of teaching modules and programs that we're actually there embedded in those programs. So we need to scope what those modules are, scope what those programs are, and make sure that when the NMC and the Social Work England are actually doing their accreditations or validations, that we're clearly there. Simple as that. And I think we need to again start to lobby the Department of Health in terms of what we mean by patient involvement. We need to refresh it all. And for me, I mean, Carol said about NHS England has cut back. I think I know the reasons why. I think now's the time for NHS England to take stock of where they're at and to rebrand it all and to start again.
Which costs millions. You know, he seems to do it every decade.
It may well do, but you know, it is again about resources, isn't it? Why are patients being the first people to be cut? As I've said before, you can't be 1 minute saying we're the best thing since sliced bread. So if we were the best since sliced bread and we're suddenly not, why aren't we? So again, coming back to something, it's about, if we're going to put money into it and resources, how are we going to monitor the outcomes of our involvement? How effective is it? Not just, oh, we're here for tea and coffee, thank you very much, and have a few jammy dodgy biscuits. That's no good. How are we going to monitor the outcomes? So that if we monitor the outcomes, we've got quantitative and qualitative analysis to say to the powers that be, this is how good we are, this is how not good we are. But you know, unless we see the principles, then we're not going to get there, are we? Sorry, I sound as though I'm being.
Okay.
But that's my opinions. That's what I think and believe. Okay. So there we go.
Thanks, Rob. I just was thinking that part of the National Clinical Audit Programme that we commission, that is often a metric. It's not. It's things like, have you spoken to the patient about their mental health, for example, would be a standard that is being measured against, and there is, so data is being collected, reported on, and then you can see outcomes of that. But that's not necessarily saying that it happens all the time and the outcomes are good, the results are good. But it is something that hopefully audits and outcome reviews are looking at. Okay, Aurora.
So going back obviously at the shared decision making and thinking about how healthcare professional can improve their practice. Number one, a reminder to all of them to slow down and to try to actively listen. I'm sure it's part of the curriculum, Rob, because me and Amit are sitting on the NMC Patient Voice Forum, so is embedded in their curricula. Is getting lost when they start the practice. I spoke quite recently with a trainee GP at my practice. It was amazing. He was the person who probably listened after a very long time, and I hope he took very good notes on the system. They need to do this even in brief appointment, because I had a brief telephone consultation and it was possible. Then obviously taking on training on using simple language for us is something that I think it came up also in this space, and they need to check for understanding. Just they can briefly reflect on the word that we are using, and then they try to be, they should be trying to ask us what is matter most to us, because doesn't mean that was matter to me, matter to other people. So they need to start this practice in the early conversation, because sometimes they have their own bias. They ask me often things because of my ethnicity, because of my background or my religion, etc., that perhaps is slightly different. Then I think they should be making sure that patients know that it's okay to ask for more information and to ask also for more time for appointment. I've been challenging sometimes healthcare professionals ask for double appointment because maybe I need to express myself in a slightly different way. It takes more time. And I also think that we should be ensuring that we have some decision aid. And if these are existing, because most of us were not even aware of this, they should be visibly offered and accessible to all. I think if you include all of these people that they have lower literacy of potentially additional communication needs, if you offer this support, the outcome is positive. Thank you.
Thank you. Really well said. Is that written down, Aurora? Are you going to send that to me? I've been recording it, don't worry. Okay, final point from Rich before we move on.
Right, okay. Okay, Kim, you asked if so there's anything to add. Okay, first of all, I agree with Meg that time is really important. Time is important to the service user in particular, and it might only kind of represent itself as a target to a health kind of professional. The second thing which I think is important is to understand the right that people have to change their mind about something. rather than kind of getting uptight and saying, well, this is what you chose. But my third thing is completely out of the ordinary, but that's to meet your service users outside of the health environment, meet them socially, and kind of get to kind of know who they are and what they have to offer. But as I say, that's completely out of the ordinary, and I wouldn't expect anybody to take it up. But it's important to remember we are humans, we have experience, we have something to offer ourselves.
Thank you. Yeah, remembering patients are human. I totally see that. Thank you, Rich.